Welcome back to the Deep Dive, the place where we condense massive, complex source material into crystal clear, actionable knowledge.
Today, you've asked for a deep, college-level summary of the histology of the female reproductive system.
And we're not just going to, recite names. We are going straight to the microscopic level to explore what is a profoundly dynamic, constantly changing system.
That's right. Our mission today is to act as your expert guides through this chapter, moving sequentially from structure to function and really paying close attention to the cellular drama that's unfolding month after month.
Yeah, this isn't static anatomy. This is a highly regulated cyclical engine.
It really is.
So to set the stage, let's get our bearings with that overview diagram. It's figure 23.1 in the source.
Right, so you can see the system includes the internal organs, the ovaries, uterine tubes, uterus, and vagina. They're all located down in the pelvis.
And then you have the external genitalia, which are collectively known as the vulva. That's in the perineum and includes the mons pubis, the labia, clitoris, and vestibule.
And we have to include the accessory structures because they're so tightly integrated hormonally. I mean, the mammary glands and the placenta.
Right, and they're all part of the same conversation.
Exactly. All these components are synchronized to support reproduction, and they exhibit these really dramatic, regular cyclical changes.
And that cycle defines the entire system, doesn't it? It starts with menarche. That's the onset of menstruation, which averages around 12.4 years old.
And it runs all the way to menopause, which averages about 51.4 years.
So for nearly 4 decades, this entire system is operating on a precise hormonal timer. So, okay, let's jump right into the engine that controls that timer, the ovary. So the ovary, it's got 2 indispensable functions.
Right. First, you have gametogenesis, which is the production of the female germ cell, the oocyte.
The egg.
The egg. And second, steroidogenesis, which is just a fancy word for the synthesis and secretion of sex hormones.
And the hormones are what drive the entire downstream system, really. The ovary produces 2 major groups, estrogens and progestogens.
Yep. And if you think of it simply, estrogens are kind of the builders and the maturators.
Okay, so what do you mean by builders?
Well, estrogens promote the growth and maturation of all the sex organs. They help establish female secondary characteristics, and they stimulate ductal and stromal growth in the breast.
And the progestogens.
Progestogens, on the other hand, are the preparers. Their job is primarily to induce these secretory changes in the internal organs, especially the uterus.
Setting the stage for a potential pregnancy.
Exactly, setting up the perfect environment. And they also promote that crucial lobular proliferation in the mammary glands, which is what you need for eventual lactation.
So structurally, what are we looking at? The ovaries are these paired almond-shaped organs, about 3 by 1.5 by 1 centimeter in women who haven't given birth.
And they're described as pinkish white. They're held in place by supporting ligaments like the mesovarium.
I want to linger on the surface description for a second. It says it's smooth before puberty, but then it becomes progressively scarred and irregular as a woman ages.
That's from repeated ovulation events. It's almost like a topographical map of a person's reproductive history written right on the surface.
It really is. Okay, so if we slice one open and look at a cross-section, which is what we see in figure 23.2.
We see the interior is broadly divided into 2 regions, but the boundary between them is often pretty indistinct. The central region is the medulla. This area is made of loose connective tissue, but its key feature is that it's incredibly rich with blood vessels. It's where all the major large blood vessels, lymphatics, and nerves enter and exit.
So the medulla is basically the vascular and neural highway.
Right. And the surrounding cortex is the active factory floor. The cortex is where we find all the ovarian follicles, and they're embedded in this highly cellular connective tissue stroma.
Now, if we zoom in on the very surface, which is shown in plate 23.1, the outer layer is traditionally called the germinal epithelium.
Right, but our source points out this is a complete misnomer.
Why is that?
Because the actual germ cells, the oocytes, they're derived from an extragonatal source way back during development. This surface layer is actually just a simple layer of cuboidal or squamous mesothelial cells.
And right beneath that surface layer, we hit the tunica albuginea.
Yep, that's the dense connective tissue layer that protects the cortex. And here's where a really important clinical insight comes in.
The cancer link.
Cancer link. The constant disruption and repair of that superficial layer during ovulation is thought to be why something like 70% of ovarian cancers arise from this so-called germinal epithelium.
Wow, so it's the repeated scarring that can lead to pathology.
It seems so. Now, let's look inside the cortex at the follicles. Oogenesis, the multiplication of germ cells via mitosis, happens on a massive scale, but only during fetal life.
And then development just slams to a halt.
It does, and that halt is a crucial detail. Oocytes that are present at birth are arrested in the diplotin stage of prophase of the first meiotic division.
And this developmental pause can last anywhere from 12 to 50 years. We'll come back to this, but that introduces some real potential vulnerability.
Oh, absolutely. And the numbers really emphasize the incredible rate of attrition here. You start with, 600,000 to 800,000 oocytes at birth, but only around 400 will ever achieve full maturation and actually be released.
That's a staggering rate of loss.
Yeah.
What's the mechanism that dictates that almost inevitable failure rate?
It's a process called atresia. It's the spontaneous death and resorption of the immature follicles. It's mediated by apoptosis-programmed cell death of the surrounding cells.
And it's not a slow trickle.
Not at all. It's a logarithmic loss that actually begins back in the 5th fetal month. Atresia is this constant, ruthless pruning process, making sure that only a tiny fraction of follicles ever even get a shot at maturation.
Okay, so now we're tracking the survivors through their stages of growth. The chapter divides them into 3 basic types: primordial, growing, and then the mature or Graafian follicle.
We begin with the primordial follicle, which you can see in figure 23.3. These are the earliest and most numerous. You find them right beneath the tunica albuginea, and importantly, they are gonadotropin independent.
They don't need hormones from the pituitary to survive at this stage.
Exactly. And you can visualize the structure pretty easily. It's a primary oocyte, very small, about 30 micrometers, arrested in prophase I, and it's wrapped in a single, simple layer of squamous or flattened follicle cells.
I remember the textbook highlighting the specific appearance of the oocyte's cytoplasm here. It contains something called the Balbiani body.
Which sounds like a geological feature, but it's really just a large accumulation of all its organelles. Golgi, ER, centrioles, mitochondria, all clustered together.
And we also see these things called annulate lamellae.
Which look like little stacks of nuclear envelope fragments. That whole accumulation is the cell's way of sort of packing its supply closet for those long, long decades of meiotic arrest.
So when growth finally resumes, we enter the primary follicle stage. That's figure 23.4.
Right. The oocyte starts to enlarge, and critically, those simple squamous follicle cells switch from being flat to cuboidal, and they start proliferating via mitosis.
And this proliferation kicks off the formation of one of the most important structures, the zona pellucida, the ZP.
The ZP is this acidophilic, PAS-positive extracellular coat that's synthesized by the oocyte itself. It forms a thick, almost glassy-looking layer. Functionally, this is the non-negotiable gate for sperm entry.
Can we break down the ZP composition for a second? The molecular specificity here is amazing.
Absolutely. The ZP is made of 4 main glycoproteins: ZP1, ZP2, ZP3, and ZP4. ZT3 and ZP4 are the critical components that act as species-specific receptors.
So they're the lock that only the right key can fit.
Precisely. They bind the capacitated spermatozoa and trigger the acrosome reaction, which releases the enzymes needed to get through. And we have to note that after fertilization, these ZP glycoproteins get cleaved by enzymes.
Which locks the door behind the first sperm.
Right. It makes the ZP rigid and impenetrable, and that prevents polyspermy.
Okay, so as the primary follicle grows even more, we move beyond just the oocyte and the ZP. The proliferating follicle cells form this stratified layer called the membrana granulosa, or just granulosa cells.
And the surrounding stroma differentiates to form the theca folliculi. That's shown well in figure 23.5.
So now we have 2 distinct functional layers.
We do. First, the theca interna. This is the inner, highly vascularized layer. These cells are specialized, cuboidal, and they are actively producing steroids. Histologically, you can recognize them by their lipid droplets and abundant smooth ER. And crucially, they have the LH receptors they need to start making hormones.
And their job is to synthesize the precursors, androgens.
Correct. The outer layer is the theca externa, which is more of a connective tissue sheath with collagen fibers and smooth muscle cells. It provides structural support.
This boundary, this separation between the avascular theca interna and the avascular granulosa layer, it seems really important. It's separated by the basal lamina. Why is that specific physical barrier so important for the follicle's function?
Well, it creates a necessary separation for the 2-cell cooperation we're about to discuss, but it's not an absolute wall. Unlike Sertoli cells in the male system, the granulosa cells lack tight junctions.
So things can get through.
Yes, and that is vital. It allows essential molecules, like the androgens made by the theca, to diffuse across the basal lamina and allows nutrients to reach the oocyte and granulosa cells, which are far from any direct blood supply.
As development continues, we hit the secondary or antral follicle stage, figure 23.6. And this is the stage where fluid liquor folliculi starts to accumulate.
Right, it pools in little pockets that then coalesce into a single large cavity, the antrum.
And the formation of that single antrum is the defining feature.
It is. The oocyte reaches its maximum size, about 125 micrometers, and just stops growing. But the follicle itself keeps expanding hugely. And meiotic arrest is still being maintained here, partly by signaling from granulosa cells, and partly by the secretion of C-type natriuretic peptide, or CNP, into the antral fluid. It's a direct maturation inhibitor.
The granulosa cells aren't just a simple layer anymore either. They start to rearrange. We see the cumulus oophoris,
Which is the mound of cells holding the oocyte.
and the corona radiata.
The immediate layer that's stuck to the oocyte, which will actually accompany it after ovulation. Histologically, you might also spot these little things called Call-Exner bodies, which are small deposits of PAS-positive material between the granulosa cells.
When the follicle reaches its maximum size, maybe 10 millimeters or more, it becomes the mature or Graafian follicle. This is figure 23.7. It bulges against the ovarian surface.
And the equal layers, particularly the interna, become very prominent, just packed with lipid, signaling that hormonal activity is at its absolute peak.
And this brings us to the absolute centerpiece of ovarian function in this phase, the two-cell collaboration for estrogen synthesis. You can see it mapped out in figure 23.8.
And this isn't just an anatomical detail. You called it the reproductive system's fundamental security measure.
Right. It ensures that the final, powerful hormone is only produced when both cell types are correctly stimulated.
That's the perfect synthesis. The whole process hinges on the fact that neither the theca interna cells nor the granulosa cells have the full enzymatic pathway needed to convert cholesterol all the way to estradiol. They have to work together.
So let's walk through the steps. Step 1, LH from the pituitary stimulates the LH receptors on the theca interna cells.
These cells then take up LDL and cholesterol and convert it into androgens, androstenedione, and testosterone. But because the theca interna lacks the enzyme P450 aromatase, they have to stop there.
So they've made the precursor.
Right. Step 2. These androgens just diffuse across that basal lamina we mentioned and enter the granulosa cells.
And these are stimulated by the other hormone, FSH.
Exactly. FSH drives the expression of their P450 aromatase. So they take the incoming androgens and, using that aromatase, they complete the conversion to estrogens, specifically estrone and estradiol.
So the theca provides the fuel, and the granulosa cell provides the final specialized tool.
That's it. Which is why our source mentions the clinical relevance of aromatase inhibitors, or AIs. By blocking that final enzyme in the granulosa cell, you stop estrogen production, which is a powerful way to treat estrogen-sensitive breast cancers.
Okay, before we move on, we have to touch on the clinical correlation in folder 23.1, polycystic ovary disease, or PCOS. This is a perfect example of what happens when that hormonal pathway gets severely unbalanced.
The symptoms are pretty clear. Enlarged, cystic ovaries, irregular periods, and ovulation, often combined with obesity and hirsutism.
And the pathology is often described visually as oyster ovaries.
Because they're smooth, pearl white, they haven't been scarred by ovulation. Histologically, this is linked to a defect in androgen biosynthesis, which leads to excessive androgen production.
And that thick, rigid tunica albuginea we saw earlier becomes a physical barrier.
It does. It mechanically prevents the mature follicles from rupturing and releasing the oocyte. And this mechanical barrier, combined with systemic insulin resistance, maintains the state of anovulation.
Okay, the stage is set. The Graafian follicle is huge, it's packed with estrogen, and now the LH surge hits. This surge is the signal for ovulation.
The release of the secondary oocyte. And it happens very precisely, about 14 days before the start of the next cycle.
And the mechanism of rupture, shown in figure 23.9a, it's this fascinating interplay of mechanics and enzymes.
It is. You have the immense follicular fluid pressure pushing outward, while inside, enzymatic proteolysis, driven by the activation of plasminogen, starts degrading the collagen in the wall.
And that's aided by prostaglandins, which stimulate the smooth muscle cells in the theca externa to contract. So it's a coordinated push dissolution, and squeeze all at once.
Exactly. And just before it ruptures, blood flow stops at a specific point on the surface. It creates this localized ischemic spot called the macula pellucida, or the follicular stigma.
That's the weak point.
That's the spot that thins and ruptures, expelling the secondary oocyte, which is still surrounded by its corona radiata and cumulus cells.
The LH surge also triggers the immediate completion of meiosis I. This results in the secondary oocyte and the extrusion of the first polar body.
But then meiosis II is immediately initiated and then arrested again at metaphase. This is the second holding pattern.
And it will only be completed if the oocyte is fertilized.
Right. If it isn't, it just degenerates within about 24 hours.
It's truly amazing to think about that primary oocyte having its meiosis arrested for up to 5 decades. The source points out that this decades-long arrest is directly correlated with the risk of errors, like non-disjunction,
which can lead to aneuploidies. The sheer temporal burden on that single cell is immense. It's a massive cellular burden.
And on a structural note, we have to consider ectopic pregnancy.
Yes, if the fimbriae of the uterine tube fail to sweep the oocyte complex into the tube, it can implant somewhere else, most commonly, in 98% of cases, in the uterine tube wall itself.
So following this successful release, the collapsed follicular wall immediately begins its transformation into a temporary but vital endocrine powerhouse.
The corpus luteum, that's figure 23.alum.
The yellow body.
The yellow body. Initially, some bleeding occurs into the cavity, forming the corpus hemorrhagicum. Then, the process of luteinization begins. The granulosa and the equital cells hypertrophy dramatically. They become packed with smooth ER, mitochondria with tubular cristae, all the classic signs of a steroid factory, and lipid droplets.
And they accumulate that yellow pigment, leuchrome, which gives it its name.
And we still have the 2 functional cell populations, just now they're specialized as lutein cells.
Okay.
Precisely. The large granulosa lutein cells make up 80% of the mass. They're central, and they produce estrogens, progesterone, and also inhibin, which suppresses FSH.
The other 20%.
The smaller peripheral theca lutein cells, they secrete androgens and progesterone. The whole structure gets rapidly vascularized thanks to the theca interna, turning it into this hypersecretory gland dedicated to pumping out progesterone.
The critical question that becomes, what's the lifespan of this temporary gland?
Well, if fertilization doesn't occur, the corpus luteum of menstruation only lasts about 10 days. Without the rescue signal of human chorionic gonadotropin, HCG, from a developing embryo, it degenerates.
Like involutes.
Right, and it forms the corpus albicans, a white hyaline scar tissue that gradually disappears over a few months. You can see that in figure 23.14.
But if fertilization does occur, the blastocyst provides that rescue signal, HCG.
And this maintains the corpus luteum of pregnancy. It persists for about 8 weeks, pumping out high levels of progesterone until the placenta is ready to take over that primary role.
Okay, so to get fertilization, the sperm must first undergo capacitation in the female tract.
And this isn't just about swimming faster, it's a required molecular change. It involves removing cholesterol from the plasma membrane and increasing intracellular CAMP and calcium. This allows the sperm to become hyperactivated, displaying this powerful whiplash motion that's needed to penetrate the follicular barriers.
Once capacitated, fertilization usually happens in the ampulla. The sperm penetrates the corona radiata, binds to those specific ZP receptors, ZP3 and 4,
triggering the acrosome reaction, releasing the necessary enzymes. The sperm then enters the perivitaline space and fuses with the ulema. Impregnation occurs, bringing the male pronucleus into the cytoplasm.
And the source highlights a key sperm-derived factor here, phospholipase C-zeta-1, or PLCZ1.
Yes, that factor triggers the calcium wave needed to resume and complete meiosis II, creating the mature ovum and the second polar body.
And then the final, ultimate line of defense is preventing multiple sperm from entering the polyspermy block. The textbook outlines a 3-step mechanism. It's designed to be swift and permanent.
Step 1 is the fast block. A transient depolarization of the ulema the instant the first sperm enters.
Step 2 is the cortical reaction.
A calcium wave triggers the release of proteases from cortical granules that are lying just beneath the ulema.
And step 3, the zona reaction, is the permanent solution. Those released proteases act on the zona pellucida, cross-linking the ZP proteins and degrading any remaining sperm receptors.
It's a complete cellular lockdown initiated by the successful entry of just one sperm.
Which leads us to the clinical triumph described in folder 23.2. In vitro fertilization, IVF. This is often indicated when the uterine tubes are damaged.
And the whole process of controlled hyperstimulation, oocyte aspiration, and external fertilization in a dish, it's all geared toward achieving the highly specific cellular events we just described.
The successful outcome, as seen in the micrographs, like figure F23.2.1a, is the presence of those clear male and female pronuclei after 12 to 16 hours.
And then the embryo is cultured to the 4 to 6 cell stage before it's transferred into a uterus that has been meticulously prepared hormonally, often with exogenous progesterone, to mimic the corpus luteum's environment.
Before we leave the ovary entirely, we have to reiterate the fate of the vast majority of follicles.
Right, atresia. Histologically, atresia is characterized by the apoptosis of the granulosa cells.
If the follicle is small, the degeneration is rapid. But in larger follicles, the process is more organized, more delayed.
The granulosa cells slough into the antrum, the area is invaded by immune cells and connective tissue, and the theca cells actually hypertrophy for a bit before they also degenerate.
And the histological signature of late atresia is the glassy membrane.
It's a thickened, wavy hyaline layer that forms between the degenerating granulosa cells and the persisting theca interna. Seeing that structure confirms that the follicle has failed.
So if the theca interna cells sometimes remain, what is their function after the follicle fails?
They often organize into clusters called corpora lutea atretica, which eventually form the interstitial gland of the ovary. And this interstitial tissue is surprisingly functional. It acts as a crucial source of estrogens during early puberty in humans before the cyclical processes fully take hold.
That's fascinating. We also briefly mentioned ovarian innervation and blood supply. The dual supply from the ovarian and uterine arteries forms these highly coiled spiral arteries in the medulla.
And the sensory innervation refers pain back to the L1 spinal nerves. That is why Mittelschmerz, the mid-cycle pain felt by nearly half of all women, is typically felt on the side of the active ovary.
And that pain is thought to be the smooth muscle contractions mediated by the LH surge leading up to ovulation.
A perfect transition, because now we follow the oocyte down the path. The uterine tubes, or fallopian tubes, shown in plate 23.4, these are the paired structures connecting the ovary to the uterus.
The tube has 4 segments. The infundibulum, with its fimbriae, is closest to the ovary.
Then the ampulla, which is the longest segment, and the usual site of fertilization.
Then the isthmus, which is narrow and medial, and finally the intramural part, which is embedded in the uterine wall.
The wall itself, you can see it in figure 23.15, has 3 layers, but no submucosa. There's the outer serosa, the muscularis, with a thick inner circular layer and a thin outer longitudinal layer, and the highly folded mucosa.
And the complexity of those mucosal folds peaks dramatically in the ampulla. It creates this huge surface area.
The mucosal epithelium is simple columnar, but it's specialized. We see 2 main cell types: ciliated cells and non-ciliated or PEG cells.
Okay, what do they do?
The ciliated cells are most numerous in the infundibulum and an ampulla, and their cilia are constantly sweeping the contents, including the oocyte, toward the uterus.
And then the PEG cells.
They're secretory. They produce the fluid that provides nutrients to the ovum and also helps in sperm capacitation. And functionally, these cells are under direct hormonal control. Estrogen stimulates ciliogenesis, literally helping the cells grow more cilia.
While progesterone increases the secretory activity of the PEG cells.
Exactly. So transport relies both on that ciliary sweeping and the peristaltic contraction of the muscularis. The oocyte takes about 3 days to travel through the tube before it enters the uterus.
And any disruption to that transit significantly increases the risk of an ectopic implantation.
Right. So moving to the destination, the uterus. Figure 23.16 shows this pear-shaped muscular organ. It's about 7.5 centimeters long in a woman who hasn't given birth. It's divided into the upper body, which includes the fundus, and the lower cervix, separated by the isthmus.
And the uterine wall is this powerful tri-layered structure. The outermost is the perimetrium, the serous layer. The thickest middle layer is the myometrium, the muscle. And the inner functional layer is the endometrium.
The myometrium, visible in figure 23.16, is a functional syncytium of smooth muscle. It's organized into 3 indistinct layers. The thickest middle layer is the stratum vasculaire.
Named because it houses massive blood vessels.
Precisely. And the functional implication of this layer is immense. During pregnancy, these smooth muscle cells undergo spectacular growth. They increase up to 500 micrometers in length, that's hypertrophy, and they also multiply hyperplasia. This leads to the massive uterine expansion needed to house a fetus.
The post-delivery involution, when the uterus shrinks so dramatically, is also a fascinating histological event. The muscle cells don't just disappear, they simply return to a much smaller size.
Though the uterus is always left slightly larger than its pre-pregnancy state.
And finally, we arrive at the most dynamic layer of all, the endometrium, the mucosa of the uterus. The endometrium, shown in plate 23.5, is lined by simple columnar epithelium that invaginates deep into the stroma, forming these tubular uterine glands.
And we have to immediately define the two distinct layers here, the functional and the basal.
Right.
The stratum functional is the thick, superficial layer that responds so dramatically to the cyclical hormonal changes. This is the layer that's sloughed off during menstruation.
And beneath it is the stratum basal, the deeper layer that's retained during menses and serves as the source for regeneration of that functional layer.
This whole distinction is dictated by the vascular arrangement, which you can see in figure 23.17. Radial arteries from the myometrium enter the endometrium. They give off small, stable, straight arteries.
And those supply only the resilient stratum basal.
Exactly. But the main branch continues upward, becoming the highly coiled, almost disposable spiral arteries.
These supply the stratum functional, and it's the distal portion of these coiled arteries that cyclically degenerate and regenerate in response to hormone withdrawal.
So the straight arteries are the stable foundation, while the coiled spiral arteries are the specialized temporary delivery system that the body is ready to tear down every single month if pregnancy doesn't occur.
That's a perfect analogy.
Mm-hmm.
And folder 23.3 provides the hormonal context for this next part. So just to recap, FSH grows the follicle, which produces estrogen.
Estrogen then triggers the LH surge for ovulation. The resulting corpus luteum then dominates the second half of the cycle, pumping out progesterone, which ensures the endometrium is perfectly prepared.
So now let's move through the 3 phases of the endometrial cycle, which is laid out in figure 23.18, assuming a 28-day continuum.
First up, the proliferative phase. This is days 5 to 14, roughly. This is the rebuilding stage, and it's driven by estrogens from the growing ovarian follicles.
Cells from the stratum basal proliferate rapidly, restoring the surface epithelium. The endometrium thickens to about 3 millimeters.
And critically, the uterine glands are straight or only slightly wavy. You can see that in figure 23.18a. The spiral arteries lengthen, but they remain only slightly coiled.
Okay, next, the secretory phase. Days 15 to 28.
Progesterone from the corpus luteum is now in charge. This is the preparation stage. The endometrium swells dramatically, reaching 5 to 6 millimeters thick, mainly due to edema.
And glands become enlarged, highly tortuous. They take on this pronounced corkscrew shape.
A sacculated appearance, as seen in figure 23.18b, and they fill with this nutrient-rich mucoid secretion. Furthermore, the spiral arteries lengthen and become intensely coiled, extending nearly to the surface in anticipation of a blastocyst arriving. This profound vascularization and glandular secretion are the visible hallmarks of maximal progesterone effect.
And finally, the menstrual phase, days 1 to 5. The corpus luteum fails, progesterone and estrogen levels just plummet.
And this hormone withdrawal causes the distal segments of the spiral arteries and the stratum functional to contract periodically, leading to severe ischemia.
Lack of blood flow.
Right. This causes the breakdown and sloughing of the entire stratum functional. The tissue, blood, and fluid form the menstrual discharge, and specialized factors inhibit clotting. The stratum basal remains intact, safeguarded by those stable, non-cyclical straight arteries.
And if ovulation doesn't happen in an ovulatory cycle, the system just stalls out.
Exactly. No ovulation means no corpus luteum, which means no progesterone. So the endometrium gets stuck in the proliferative phase until the existing estrogen triggers a breakthrough bleeding event, bypassing the organized secretory phase entirely.
But if fertilization does happen, the cycle stops and we enter the gravid phase.
The truffle blast rescues the corpus luteum via HCG, maintaining progesterone, which prevents the inevitable collapse of the spiral arteries.
And implantation requires specific timing. The zygote cleaves into a morula, which enters the uterus around day 3, and then develops into a hollow blastocyst.
And the implantation window is surprisingly short, just days 6 to 10 after the LH surge. If progesterone levels drop, this window closes, which is the mechanism of action for anti-progesterone drugs like mifepristone.
The blastocyst has to invade. The outer cell layer, the trophoblast, it differentiates. The inner layer is the cytotrophoblast, which is mitotically active.
And the outer layer is the syncytiotrophoblast. The syncytiotrophoblast is the aggressive force. It's this multinucleated cytoplasmic mass that is erosive, actively invading the endometrial stroma. It's also the source of crucial hormones, including steroids and HCG, which are vital for maintaining the pregnancy.
And meanwhile, the endometrium responds to this invasion by undergoing decidualization. The stromal cells differentiate into these large, pale decidual cells packed with glycogen.
And they form the decidua, which is the tissue that will be shed after delivery. Histologically, we identify 3 regions, as seen in Figure 23.12. The decidua basalis is located directly beneath the implantation site. This will become the maternal part of the placenta. The decidua capsularis covers the implantation site facing the lumen. And the decidua parietalis is all the remaining endometrium.
And by month 3, the uterine cavity is obliterated as the capsularis fuses with the parietalis. Okay, the placenta, the ultimate temporary organ facilitating fetal and maternal exchange. It's composed of the fetal chorion and the maternal decidua basalis.
And primitive uteroplacental circulation starts incredibly early, around day 9, when these vascular spaces, the trophoblastic lacunae, connect with maternal sinusoids.
The fundamental functional units are the chorionic villi. Their development is sequential, right? You can see that in Figure 23.26.
Yes. Primary villi, around days 11 to 13, are just simple cytotrophoblast cords pushing into the syncytiotrophoblast.
Then secondary villi, around day 16, are where the core gets invaded by mesenchyme.
And by the end of week 3, we have tertiary villi, where that mesenchymal core has become vascularized, connecting to the nascent embryonic circulation.
So the mature placenta features 2 types of villi, anchoring villi and free, or floating villi.
Histologically, the villi consists of the syncytiotrophoblast outer layer, the inner cytotrophoblast, which becomes discontinuous at term, and a core containing fibroblasts and these Hofbauer cells.
Placental macrophages.
Right, they're thought to have antigen-presenting functions. The crucial structure, of course, is the placental barrier, which separates maternal and fetal blood. It thins dramatically by the 4th month to optimize gas and nutrient exchange.
And at its thinnest, the source says 6 components must be crossed.
Right. The syncytiotrophoblast, the cytotrophoblast, the trophoblast basal lamina, the mesenchymal core, the basal lamina of the fetal capillary, and the fetal capillary endothelium.
It's important to remember that this barrier is highly effective for some things, but not for others.
Oh, definitely. It allows O2, nutrients, waste, and crucial antibodies like IgG to cross, but it's permeable to harmful agents like alcohol, drugs, and many viruses.
Circulation, as shown in Figure 23.29, involves the fetal blood arriving at the placenta via 2 umbilical arteries and returning via 1 umbilical vein.
And on the maternal side, you have 80 to 100 spiral endometrial arteries pumping blood into the intervillous spaces. We're talking about a volume of about 150 milliliters being exchanged 3 to 4 times a minute. It's then drained back via endometrial veins.
And clinically, Folder 23.4 addresses abnormal placentation. This is when the trophoblast invades too deeply, usually because of a compromised decidua basalis.
Right. Placenta creta attaches deeply into the wall. Placenta increta penetrates deep into the myometrium, and the most severe, placenta percreta, penetrates through the entire uterine wall, potentially adhering to external organs at the bladder.
These conditions are major causes of massive postpartum hemorrhage.
They are. Now, endocrine function is also massive. The placenta produces progesterone itself and peptide hormones like HCG and HCS, but for estrogen, we have that specialized fetoplacental endocrine unit.
Because the placenta can't do it alone.
Exactly. It lacks the final enzyme pathways, so it relies on precursors from the fetal adrenal cortex. The placenta takes these fetal steroids and completes the final conversion to estrogen, ensuring the high estrogen levels that are crucial for maintaining the pregnancy.
Okay, let's switch focus to the cervix. Figure 23.21 shows how the histology differs sharply from the uterine body.
The mucosa is thin, only 2 to 3 millimeters. It lacks spiral arteries, and so it is not sloughed during menstruation. It contains these large branched glands that produce mucus.
And the cervical mucus is highly cyclical, responding to ovarian hormones. At mid-cycle, it increases tenfold in volume and becomes thin and less viscous.
To facilitate sperm migration. At other times, it's thick and blocks passage, and blockage of these glands is common, resulting in Nabothean cysts.
The site of greatest clinical relevance is the transformation zone. That's in Figure 23.23. This is the abrupt histological meeting point between the stratified squamous, non-keratinized epithelium of the ectocervix
and the simple columnar epithelium of the cervical canal, or endocervix.
And this region is highly active, prone to metaplasia.
where the columnar cells are reversibly replaced by stratified squamous epithelium, likely due to the acidic environment of the vagina. And this transition zone is precisely where precancerous lesions and cervical cancer most frequently originate.
which underscores the vital nature of the Pap test. Folder 23.5 explains this is a screening method using exfoliated cells to detect cellular abnormalities.
And also to evaluate the hormonal status and microbial environment. The protective acidic pH of the vagina is maintained by Lactobacillus acidophilus, which ferments glycogen from desquamated epithelial cells into lactic acid.
Which brings us to folder 23.6, the link between human papillomavirus, HPV, and cervical cancer.
High-risk types 16 and 18 are the leading cause. And the ability to use HPV testing alongside cytology has really refined screening guidelines. Vaccination, like Gardasil 9, remains a massive preventative tool.
Okay, we're shifting now to the final segment, covering the rest of the tract and the external structures. We start with the vagina, that's figure 23.3.
It's a fibromuscular tube lined by stratified squamous non-keratinized epithelium. Histologically, if you look at a slide, like in plate 23.10, those epithelial cells often look empty.
Because the abundant glycogen they contain is washed out during routine tissue processing.
Exactly. And the vagina is unique because it lacks glands. Lubrication is solely provided by cervical mucus and the vestibular glands.
The vaginal wall has 3 layers: the highly folded mucosa with its rugae, the muscular layer, and the outer adventitial layer, which is rich in elastic fibers.
Making it highly distensible. And again, estrogen drives the epithelial accumulation of glycogen. When those cells are shed, the glycogen is fermented by the protective bacterial flora Lactobacillus acidophilus to maintain that acidic pH of about 4.
Which is crucial for inhibiting the growth of most pathogenic microbes. Let's move to the external genitalia, the vulva.
The mons pubis is the adipose prominence over the pubic bone, covered in hair, and its skin is rich in sebaceous and apocrine glands, plus numerous sensory receptors.
The labia majora are the 2 large, prominent longitudinal skin folds. They contain hair follicles, multiple gland types, a thin, smooth muscle layer called the dartos tunic, and significant subcutaneous fat. They are essentially modified skin folds.
And deep within them are the major vestibular or Bartholin glands. These paired tubuloalveolar glands are homologous to the male bulbourethral glands, and they produce critical mucus for lubrication during arousal.
And blockage of the long duct can lead to cysts or abscesses.
Right. Contrast that with the labia minora. These are the inner hairless folds. They lack adipose tissue entirely in their core, but they are exceptionally vascularized and rich in elastic fibers.
And the defining feature of the labia minora is their innervation.
It is. They possess the highest concentration of specialized sensory receptors, Meissner and Merkel corpuscles, in the entire vulva, making them acutely sensitive.
Next is the clitoral complex. It's often called an iceberg because only the glands is visible, about 10% of the total structure.
The complex includes the body, crura, and the bulbs of the vestibule, and it is massively innervated, particularly with Pacinian corpuscles.
And we distinguish between 2 types of specialized vascular tissue here.
We do. Erectile tissue found in the body, crura, and bulbs consists of wide, irregular vascular spaces surrounded by connective tissue and smooth muscle. These spaces fill dramatically with blood, causing physical volume expansion upon arousal.
And then there's non-erectile vascular tissue.
Found in the glands, labia minora, and vaginal adventitia. This tissue is dense with vessels but has minimal surrounding smooth muscle. So while it receives high blood flow, it doesn't undergo significant physical expansion or erection.
And the bulbs of the vestibule are unique.
They often lack a distinct tunica albuginea, which allows for immense swelling during engorgement.
Finally, the vestibule, the area containing the vaginal opening and external urethral orifice. It's lined by stratified, squamous, non-keratinized epithelium.
A fascinating footnote here relates to the periurethral, or skenes, glands. These are accumulations of glandular tissue surrounding the urethra.
And the source notes that histologically, these glands are remarkably similar to the male prostate.
They even stain positively for PSA and PAP, and they contribute to secretions during sexual excitement.
That's incredible comparative histology. Okay, let's wrap up with the mammary glands. These are modified tubulo-alveolar apocrine sweat glands, and their structure changes constantly throughout life.
In the inactive gland, as seen in plate 23.11, the parenchyma is sparse, dominated by duct elements, separated by dense connective tissue and fat. That connective tissue forms the suspensory or Cooper's ligaments. The basic functional unit is the terminal duct lobular unit, or TDLU.
And during pregnancy, the active gland transforms completely.
The 3 trimesters involve spectacular growth, elongation, branching, and differentiation of the terminal ductules into fully functional secretory alveoli. The stroma becomes infiltrated with immune cells, notably plasma cells, which contribute antibodies to the milk.
Milk production itself uses 2 distinct secretory mechanisms, right? This is figure 23.45.
It does. The protein component is synthesized in the rough ER and released via merocrine secretion, which is standard exocytosis.
And the fatty lipid component.
It coalesces into large droplets and is released, enveloped in the apical plasma membrane, via apocrine secretion.
The initial secretion, colostrum, is alkaline and antibody-rich, especially with IgA, providing passive immunity to the newborn.
And the control of full lactation is a neurohormonal reflex. Prolactin, or PRL, initiates milk synthesis, and suckling stimulates oxytocin release,
which causes the contraction of myoepithelial cells around the alveoli and ducts the critical letdown reflex.
And we noted the functional consequence of high PRL. It suppresses GnRH and LH, leading to lactational amenorrhea or temporary infertility. When lactation ceases or postmenopause occurs, the glandular tissue undergoes involution, atrophying, and being replaced by fat and connective tissue.
We have truly traversed the microscopic landscape, tracking the dynamic cycles step by step. We saw the ovaries' genius in that 2-cell collaboration for estrogen production,
the cellular security measures for fertilization, and the incredible, rapid formation and precise lifespan of the corpus luteum.
And we follow the consequences of that hormonal timer. From the straight arteries supplying the resilient foundation of the endometrium to the spiral arteries supplying the disposable functional layer, adapting month after month.
We explored how everything, down to the specialized innervation of the clitoris and the protective acidity of the vagina, is just designed for the potential of reproduction.
It's a system built on change, which leads to our final thought. Given the complexity of coordinating the hypothalamus, pituitary, ovary, and uterus.
And considering the primary oocyte has to survive in meiotic arrest for potentially 50 years, enduring hormonal fluctuations, environmental changes, mechanical stress.
How remarkable is the body's resilience and capacity for nearly 4 decades of incredibly precise, repeatable function?
It really speaks to the power of molecular feedback loops and cellular specialization. It is a stunning example of physiological synchronization.
Indeed. Thank you for joining us for this intensive deep dive into the microscopic world of female reproductive histology. We'll see you next time.